Okay na po ba ang lahat?
Yes. Yes.
Okay. So the Philippine National Anthem.
Mga kababayan, ang pambansang awit ng Pilipinas.
Ay damdamin, suliranin itong baya'y pawiin. Inalangin natin ng tapat sa may kapal, ay lunas sa lahat. Awit ng DNA, tayo ay mag-iwan. Magtulungan, magunlad ng bayan. Ang kailangan, ibigay sa kanan. Kalusugan at kasaganaan. Ang puso ko'y tigib ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may hintong rasa, magising at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pawiin. Inalangin natin ng tapat sa may kapal, may lunas sa lahat. Inalangin natin ng tapat sa may kapal, may lunas sa lahat. Namin sa may kapal, pagkabay niya ang pinagdarasal. Tungkulin namin ay ang maglingkod sa mga mamamayan ng aming lungsod. Kami ang mga manggagamot ng Olongapo. OCMS, karamdaman may lunas. OCMS, anuman ang dinaranas, lahat ay gagawin para sa pagaling. OCMS, patungo sa hinaharap. OCMS, kalusugan naming pangarap. Sinumpa ang tungkulin ay tutuparin. Kami ang OCMS.
Maraming salamat po.
So now po to give us an opening message, the President of the Olongapo City Medical Society, Dr. RJ Manzo.
Thank you, Maron, and thank you to everybody in this meeting. This evening, we are so lucky to have invited 3 of our local dentists from the Philippine Dental Association, Olongapo chapter. And I believe this is the first time po na nagkaroon ng collaboration with our friends from the dental profession. We hope this can be the beginning of further collaborations. Maraming salamat po sa inyo. And napakahalaga po ng ating pag-uusapan ngayong gabi. Our February is Oral Health Month, And our oral health has been emphasized to us all as early as we can remember. During our formative years, when our parents and guardians first taught us how to brush our teeth, and when we had our very first dentist appointment. This is a very important part of our overall well-being, and the OCMS thought it best to educate us, but the experts themselves. So again, we are so thankful to have with us tonight our experts from the Philippine Dental Association Olongapo City Chapter. Pag-uusapan din po natin ngayong gabi ang isang topic na hindi commonly napapag-usapan, ngunit napakahalaga din nating malaman. Since this is Oral Healthcare Month, we had the opportunity to incorporate our cancer advocacy tonight and to talk to us about our oral cancer awareness. So this is our, I think, 11th lecture. One of our local experts in ENT na nagpapasalamat din tayo at napagbigyan niya ang ating imbitasyon. So without further ado, let us get this show on the road, and I am excited to learn tonight as all of you. On behalf of the OCMS, welcome to our oral health webinar.
Thank you, Dr. RJ Manzo. So, is everybody ready? Ready na po ba ang lahat? So, let's begin. So, our first lecture is Dr. Daryl Eustaquio. So, the title of her lecture is Healthy Smiles and Healthy Body. So, a brief background about Dr. Eustaquio. Graduated Doctor of Dental Medicine, University of the East, 2010. She had her pediatric dentistry residency training in the Pediatric Dentistry Center of the Philippines, and also a mini residency in the same field at Indiana University. She is a pediatric and special needs dentist at the Smile Concepts Implant and Cosmetic Dentistry Clinic inside SBMA and in Judith A. Direct Dental Clinic in Olongapo City. So, Dr. Eustaquio.
Hello, yes, good evening po, Doc.
Ayan. Hi, Doctora. So, you may begin po with your lecture.
I'll just share lang screen share. Hindi ko lang.
Okay.
Oops, wait lang. Ano na nga ulit, Doc, mag-share?
Nasa taas po yung share content po.
Share screen, tapos advanced, tapos portion of screen.
Nawala yung share screen, advanced video.
Advanced, tapos portion of screen, tapos rehearse slideshow. Okay.
Kita lang, Doc?
Yeah,
Yes.
perfect.
Okay.
Thank you.
So, good evening, doctors. I am Dr. Daryl Eustaquio. I practice pediatric dentistry and special needs at Smile Concepts sa SBMA and with Dr. Judith A. Daryl. Today, I will be discussing to you about dental caries and how we can prevent them. So, disclaimer lang po, I am not affiliated or connected to any of the products that I'll be showing in this presentation. And if medyo mabilis po, pwedeng paki-raise your hand para ma-call po yung attention ko lang, no? So, kamusta po ba ang dental problems dito sa Pilipinas? According to NMEDS, no? Back in 1998 pa po to, about 92.4% of the Filipinos have dental caries and 78% has gum disease. So, paano pa kaya today, no? Kung 1998 pa. So, tas ngayon, lagi tayong nagmamask. And I'm sure marami tayong nakikitang mga joke na post na parang, hey, don't forget to brush kahit naka-mask. No? So, what is dental caries? So, dental caries is actually the oldest and the most common disease found in humans. all experts agree that dental caries is an infectious and communicable disease, and that it is a multifactorial that influence that initiates and progresses the disease. So what are the factors or the determinants of dental caries? So in principle, dental caries may develop in any tooth site. So that means may it be a grooved area, so yun like sa bagang natin, or those of the smooth surfaces like sa front teeth natin can be affected. So as long as there is dental plaque or the microorganisms, the collection of microorganisms formed because of the dietary sugars with what we eat, so ang dami natin kinakain na starch, carbohydrates, and if they are allowed to accumulate over time, then pwede tayong magkasira ng ngipin. Of course, the ones in the circle right now, are the biological determinants. And these biological determinants can be also influenced by the following. So one part is yung saliva. The saliva is actually, it's like our natural cleanser. So if there is any decrease of saliva production, then what happens is mas nahihirapan yung body natin to cleanse out our mouth. That's why, di ba, pag gabi, when we wake up in the morning, because our saliva isn't really acting as much in comparison in the morning, lalo na, like ngayon, I do the talking. So yung saliva ko, it's really producing a lot of it, no? So if pagtulog tayo, it's not producing so much. So mas madaling mag-attack yung bacteria on our teeth. Also, the education, the socioeconomic status, attitude, and behavior of the patient. So here falls yung mga, yung dental IQ of our patients. So if they have this attitude of, oh, baby teeth lang yan, or sadly, even sa States or even sa first world country, this is still their problem. Na mas important yung medical condition of the patient if, let's say, of the special needs yung patients natin, no? So without knowing, like for example, if the patient has cerebral palsy, doc, laging nagsi-seizure yung anak ko or yung kapatid ko. But without knowing yung pala, ang cause pala ng seizures na is the dental cavity, no? So over time, the acids will demineralize the tooth, and the earliest sign of dental caries is tinatawag nating white spots lesion. So just like us, pag nagkakasakit tayo, first thing that would happen is namumutla tayo, di ba? So if demineralization continues, the surfaces of the white spots will cavitate, and magiging cavity siya, no? So also, these white spots would be easily stained din siya. And it will easily break or fracture. Now, ito na yung dental cavity. Most of the time, if it's broken already like this, kumbaga, ang hirap ng habulin na via pasta lang po siya, no? So, why does it matter, no? So, let's start with baby teeth. So, the baby teeth kasi, if there is any severe caries in the primary teeth, it would be a predictor for us that the caries, that the permanent teeth nga, there's a high chance that it would be also of severe caries din siya, no? So, I'm not sure if sa patients ninyo may nababanggit, but when I interview my patients, no, well, the parents, bale, they would usually say, ako, Dok, kasi nung bata ako, panay sira yung ngipin ko. Kaya ngayon, nakapustiso ako, naka-jacket ako. These permanent teeth are just like newborn babies, no? So if may bagong tubo and the environment that the permanent teeth will come out is pangit or maraming sira ng ngipin, then there's a very high chance that they will get infected then. Another one is it also affects speech. So there are letters that we need our teeth to pronounce, like N, D, T. So minsan nga, nagiging problem of those with the speech therapist, Doc, bubunutin niyo yung ngipin. Pero yung bubunutin ko, upod na yung harap ng ngipin niya. Wala na siyang ngipin. It's just infection ang natitira doon. No? It also affects nutrition. I have patients, I'm sure you also have patients or parents, grandparents, buong barangay, worried sila na, Dok, sira-sira yung ngipin ng anak ko, paano yan, bubunutin ni Doktora Dada, no? Paano kaya yun kakain? But honestly, I have patients who I have extracted lahat ng ngipin in one sitting, though the patient would be under sedation. No? Doc, you'll extract all teeth. Paano yan? How can he eat? How can she eat? After 1 week, bigla sabihin, pagbalik sa akin upon check-up, Doc, grabe ha, nagbunot ka lang ng ngipin, pero sobrang kain naman niya ngayon ng pagkain. Because now, since wala nang masasakit sa ngipin niya, mas nakakakain na siya. The patients would eat more than lugaw lang siya. So, may mga biglang nagwo-weight gain din po. And, syempre, affects body image, self-esteem. So, may iba na parang nagkapustiso lang, biglang makikita nila, oy, instant facelift, doktora, ang pustiso pala dito, no? Tapos, or even our artists, mga artista natin, makikita natin, perfect smile, super, super nice. And mas confident sila when they smile, no? So, like I said din kanina, Dok, nung bata lang kasi ako, sira-sira na yung ngipin ko. Pero ngayon, at panay pustiso na po ako sa pagtanda, I don't want that to happen to my child. So, can you imagine, bata pa lang sila, dala-dala na nila yun up until sa pagtanda nila, up until sa nagkaanak or apo na sila. They don't want that to happen because it affects their self-esteem. And pinakaayaw ng lahat, mapasa ang field tayo ng medicine, dentistry, or kahit sa allied health tayo. Kinakatakutan ng lahat is yung mga treatment, no? Yung mga bayarin. No? So, of course, di ba, it's the same as your field, mga doc, no? So if you take care of your body early in life, it would be less costly, less medications, less maintenance, no? So yung check-up, yes, minsan nakakainis, no? Sabihin nila, wala naman ako sakit, bakit ako mag-check up? But then, yung gastos na ginagamit nila for the check-up, in comparison, kung marami na silang sakit, tapos doon sila magpapa-check up, mas maliit yung ginagastos nila na yun. And eventually, yung white spots na yon, they will become something like this, no? Very, very common to sa practice ko, halos every day. But mas nakakatakot if ang cases natin is maging ganito pa, full-blown cellulitis. So, I'm sure may iba po sa inyo na ER po to, no? Tapos na-admit. So, may dasal pa po tayong kasamang wag po sana maging lubric angina, sepsis, or infectious endocarditis. Ako po, pag nakakakita ko niyan, dinadasalan ko din po na wag magtuloy-tuloy ng ganun. So, but how can we prevent these, itong mga sira na to? May it be adults or kids po to, no? So, isang madaling salita lang po, brushing, no? Pero hindi lang po pala brushing ha, proper brushing. So, paano po ba yung proper brushing? No? So, let's start with the toothpaste. A lot of patients will ask us, Doc, ano bang magandang toothpaste na pwedeng gamitin? So, a lot of research has been made and confirmed that fluoride helps on preventing and controlling the dental caries. No? We think of it as a medicine din po. No? So, as long as if it is on the right amount of the right concentration, it would be safe naman po siya, no? So, we really look at the labels of our toothpaste, just like any of our food. Ngayon, very conscious na tayo with the food. We read the labels, no? So, we have to check na 1,000 to 1,400 ppm yung fluoride content nila. And according to Cochrane database, that the fluoride na of that amount, 1,000 to 1,450, shows na they reduce the amount of decay on their subjects. Doc, how can we see it? Sa likod nga po, no? But honestly po mga doc, no, ang dami nila. You have to check that the word fluoro. Kasi hindi naman lahat ng toothpaste, they write 1,000 ppm fluoride or 1,450 fluoride. May iba monosodium fluoride na naka-percentage. Honestly, sa sobrang dami nila, myself, I don't really remember it. So what I do, I take a photo, I search it, or pag-uwi ko. But most of the time, the adult toothpaste, they are of 1,000 ppm to 1,450. With the Filipinos, most of the time, I recommend the 1,450 because we are very, very high risk on having cavities because we eat a lot frequently, no? So, minimum of 1,000 po dapat tayo. And like I said kanina, it should be of the correct amount of fluoride on the toothbrush. So for kids of 3 years old below who cannot spit, literal naggapahid lang. With me, with my son who he's 3, I opened the toothpaste, yung pinakatakip, yun lang yung kinukuhanan ko ng toothpaste, not sa mismong tube na area. It's just a smear amount of fluoride. Well, now he's 3, he can spit. Pwede na siyang pea size, no? And pag 6 and above, pwede na po yung full head po ng toothbrush natin siya. And proper brushing technique. We don't just do in and out, in and out. Because when we do in and out on our brushing, sinisira po natin yung ngipin natin. It's like us getting papel de liha and then kinikis-kis po natin yung ngipin natin. So how are we gonna properly brush it? You angle a little bit into a 45 degree. So medyo masasama po konti yung gums natin so that we can clean yung pinaka-junction of the tooth and the gums po, or circular motion. With the kids, I noticed the circular motion is really easy, especially if they're batang-bata pa po, no? So, and not less than 2 minutes. It would take at least the proper brushing na 2 minutes for us to properly clean yung ngipin natin. Ideally po, no? So, what if naman, Doc, paano naman kung infant or paano po with medical, with special needs? Of course, hindi tayo exact 2 minutes. Matatagalan po tayo. So, spit and no rinse. Yes po, no? Parang nasanay tayo, we always spit when, we always rinse after brushing. Why do we have, bakit di tayo mag-rinse? Because remember, the fluoride is the one that helps prevent the cavities. So if you rinse ng water, you're actually rinsing out the fluoride. So yung fluoride napunta lang sa sink natin, no? So you want that fluoride to stay inside your mouth. And day and night, common po, lalo na with pedia and special needs po na patients natin. Kasi mahirap po sila sipilyohan, I understand. Kahit ako, nahihirapan din naman po ako, no? Na most of the time, morning lang nila nasisipilyohan pagkaligo. But remember, like I said kanina sa first few slides ko, it is a multifactorial ang influence po ng caries. So, included yung saliva, and that saliva sa gabi, hindi siya ganun ka-active. So, dapat, the last thing that we will do at night is brushing po. That's what we tell to our patients po, no? So, kailangan po talaga, last thing to do is the brushing po. So, just a recap, the golden rules for us is 1,000 to 1,450 ppm of fluoride dun sa toothpaste, correct amount of toothpaste on toothbrush. So, if it's 3 below who cannot spit, smear lang or rice lang, yung grain of rice lang yung amount niya. If it's 3 and above, 3 to 6 years old who can spit, pea size. And if older than that, then pwede na po yung the whole head of the toothbrush. The brushing technique should be in a 45 angle or circular in motion. At least 2 minutes for us to fully clean our teeth. Spit and no rinse so that the fluoride would stay inside the mouth day and night. And brushing should be the last activity po ang gagawin. So, if you have patients of special needs, Doc, how are we gonna brush that? Hindi nga namin mabuksan. Ang hirap po talaga. Here is a photo po, no? So, I recommend my patients sometimes, I tell them, here are the tips. Of course, not everything is one size fits all yung dating mo. So I tell them, try nyo ito, and then if this work, then good for you. If not, then let's try another technique. So one is yung maliit lang na bimpo or yung baby towel, you roll it up so that meron lang siyang makahagatan yung pasyente, so that medyo ma-open yung mouth niya. Or para mas medyo may body yung baby towel, i-roll mo yung baby towel sa chopsticks so that mas matigas ng konti, no? And the baby towel would work as a cushion para hindi naman masira agad ni patient yung chopsticks. Pwede din yung dalawang brushes, yung head to head niya para ididikit para maging pang-open ng mouth siya. Another one is actually the tongue depressor, and then you put gauze on one end of the tongue depressor and you tape it with yung masking tape. Medyo mas mabusisi lang yan and mas madami yung bibilhin ng patient, pero disposable kasi siya, no? And of course, nakahiga or at least medyo naka-recline yung patient. Why? Why kailangan naka-recline? Kasi if nakaupo lang yung patient, masasalaksak niyo siya while you brush his teeth, no? So, if nakasandal yung patient, may resistance and may support bali yung neck niya, hindi ka masasalaksak. Hindi mo masasalaksak yung patient. And if let's say, Doc, the gag reflex ng kapatid ko, sobrang lakas talaga, madikit ng check the head of the toothbrush. If let's say the head is really, really big, of course, kahit sino magagag agad talaga siya. So, there are cases na yung parents would ask me, Doc, ako kaya anong toothbrush sa akin? Kasi ang hirap talaga i-reach, nahihirapan ako. I tell them, use a kiddie toothbrush. The head is really small eh. So, mas ma-reach nila, mas less gag reflex. Hindi siya parang full inside the mouth. Remember, if the patient is of special needs, meron ka nang pang-open, tapos meron ka pang toothbrush. Baka mas, kung hindi ka pa sanay, magagag talaga yung patient, no? And for kids, the photo pala po here is prior to COVID po, ha? That's why medyo ganyan po yung setup natin, no? We do a knee-to-knee. So, this is actually what I did with my son. Hanggang ngayon, well, hindi na knee-to-knee, nakahiga na lang kami sa kama. But this is how we did it po, no? So, sorry, I don't know if you can hear it. I also make sure to sing, may it be with kids or with special needs, because most of the time, they are pattern, sanay sila sa pattern eh. So, with this one, I sing Twinkle Twinkle hanggang ngayon. He is below 1 years old pa po niyan. And then you notice my finger, I lift the lip up or sa baba, even the cheek, nire-retract ko po. Why? So I can see it clearly po, no? So also the tongue, kailangan din po natin siyang sipilyohin po yung tongue. Kasi most of the time, dumidikit din po yung bacteria po doon. That's why bad breath po, diba? Lalo na kung formula yung iniinom po ng bata. So, here he is at 3 years old. Same pa rin po yung style namin, no? So, you can see I am really retracting the cheeks, the lips. Pero mga doc, honestly, dati sinasapian po yan ng masamang espiritu. Nasanay lang siya kasi araw-araw yan talaga yung gawain namin, day and night, no? So, with the patients, with or without special needs kids, this is what I do din po. So, same song, after 3 years, even the brushing of the tongue, I do the same song din. And also, if you're wondering how long nagsusurvive yung toothbrush ko, there come a time na naging every week nagpapalit kami kasi ninangat-ngat po niya talaga. No? So with this, I end my presentation. Thank you po.
Thank you, Doctora. So if you have any questions, it will be accommodated at the end of the 3 lectures for today. So for our next speaker, is Dr. Johann Christopher S. Ong, with his lecture titled Safer Dental Visits in the New Normal. So a quick background of Dr. Ong. Graduated Doctor of Dental Medicine, Central Escolar University, 1998. had his training in cosmetic dentistry at the Philippine Academy for Aesthetic Dentistry, PAED Aesthetic 101, and MIS Implant System Training Program 2015. He is also the owner and the head dentist at the Smile Concepts Implant and Cosmetic Dentistry Clinic inside SBMA. So, Dr. Ong, you may start your lecture. You may share your
Hi,
screen.
good evening.
Good evening.
Paano ba to? Wait lang. Which one? Basic. Okay. Okay, so good evening po. Thank you for the opportunity. Am I clear?
Yes, Doc. Aba.
Hello? Clear po audio?
Clear, Doc. Clear.
Yes po.
Yes, Doc, yes.
Yeah. Hi, good evening po. Can you hear me now?
Yes, Doc. Clear po. Clear.
Opo. So, good evening. Thank you po for inviting the Olongapo City Dental Chapter para po maka-join sa inyong webinar for tonight. Good evening po sa mga kaibigan ko sa OMS. So, ngayon po ang topic ko po is titled Safer Dental Visits in the New Normal. So, alam naman po natin na wait lang po, check ko yung slides ko. Ayaw pong lumipat. Okay, so yun na po. So, introduction po. So, alam po natin na the coronavirus disease altered society and the practice of medicine and dentistry dramatically. So, yung po mga hindi natin dati ginagawa, ngayon po ginagawa natin. No? So, never po natin na-imagine na magiging ganito po kalaki yung impact sa practice po natin. Nung nagsimula po yung lockdown years ago, I was thinking like maybe 3 months, 6 months will be fine. But now, 2 years in, ganun pa rin po tayo. No? Although it's improving, salamat po sa Lord at sa mga kaibigan po natin, doctors, gumaganda na po yung ating condition. Sana po tuloy-tuloy po tayo. No? And then, it was declared global pandemic on March 11, 2020. So, SARS-CoV-2 virus primarily spreads via respiratory droplets or particles such as those in aerosols when a person coughs, sneezes, speaks, or breathes. Sa dental practice po, no, when we use the scalers, the handpieces, or when we do procedures na nag-generate ng aerosols, yun po, na pwede pong ma-spread ang virus po. So ano po yung naging effect sa dental profession? So napakarami pong effect. Una-una po, closure of clinics. Ako po, I was closed from March to June 2020. I'm sure marami rin pong ibang nag-close sa mga kasama po namin dito sa Olongapo. And then, yung iba po, permanently nag-close na sila ng clinic nila. And then, isa pa pong effect is the high cost of PPEs and other dental materials. Before ECQ, a box of surgical masks is around 120 pesos per box. So during ECQ, or probably around May or June, one box would cost us 1,500 pesos per box. And then yung mga gloves, Ganun din po, from 180 became 700 pesos per box. So tumaas po talaga. And also, hindi lang yung mga PPEs, kundi yung other materials kasi yung shipment, nahirapan, yung delivery, nahirapan. So lahat po tumaas talaga yung cost, no? And then, burden of acquiring new equipment. Sa dental practice po, kailangan namin ng mga new equipments para po magamit to stop or minimize the spread of aerosols. Mamaya po pupuntahan po natin yan. And then, we limited our patients to create spacing kasi ayaw po natin magkaroon ng siksikan sa waiting area, and most dental clinics, maliliit lang po yung mga waiting area. So ayaw po natin magka-crowd yung mga patients natin doon. And then shortened work hours kasi kailangan pong makauwi ng mga clinic staff natin dahil limited po yung transportation during those times. And then physical and mental health challenges, no? So ang hirap po, noon di naman tayo nagko-coveralls. And then suddenly, kailangan natin mag-coveralls. And then kailangan natin mag-respirator. So ang init, ang hirap huminga, masakit sa katawan. Then mental health challenges, no? Kasi nandiyan lagi yung fear na baka magkasakit ka. And then patient hesitation. Marami pong patients na natakot pumunta dahil baka mahawa daw sila sa COVID. So possible naman talaga, di ba? Meron po ko mga patients, just imagine for 2 years, no? Ngayon lang sila bumabalik for their regular appointments. So aerosols and droplets. So in this illustration, makikita po natin na kung paano po na-spread ang virus sa dental setup, kung paano po possible na ma-spread, no? So we used hand pieces, no? Ito yung pang-drill natin ng mga cavities. So the handpieces, the scalers, they generate aerosols, no? So kasi may water yan combined with compressed air. So talagang aerosols go flying all over the clinic. So lumilipad sila. And then yung droplets pa. So kaya kailangan natin talaga ng mga equipments. And then syempre in the surfaces, no? When the aerosols would land on flat surfaces, naiiwan sila doon, yung viruses pwedeng mahawakan ng patients, pwedeng mahawakan ng staff, magkakaroon tayo ng cross-contamination. And then, what is the hierarchy of controls para sa COVID? So the most effective is elimination. So kung ma-eliminate natin yung infected patient, so ang laki po ng chance na ma-stop na yung pag-spread ng virus. And then substitution, according to Cornell University, wala pa pong nakikitang substitution. Engineering controls, ito po yung mga ventilation, mga equipment na ginagamit po natin. Admin controls, paano po magtatrabaho yung mga staff. Always tell my patient, my staff na huwag kayong sabay-sabay kumain, no? Kasi napaka-close nila, gusto nila sabay-sabay sila kumakain. As much as possible, I discourage it na magsama-sama sila kasi alam niyo na baka magkahawahan sila if ever, no? And then of course our PPEs. Then this is our clinic safety protocols, no? And I think most of our dentists ganito rin po yung ginagawa. So number 1 is clinic and patient communication. Napaka-importante po nito. So we use messaging apps like Viber, Messenger to contact our patients. And then madalas pa rin through text messaging. So ano po yung laman ng mga text namin sa kanila? So usually it's the date and the time of the appointment. And then we send them our protocols, kung ano yung kailangan nilang gawin before they go to the clinic or pagdating nila sa clinic. Kasama na rin doon yung initial screening, like if you have symptoms like coughs, colds, sore throat, nakalagay na yun na hindi namin kayo ma-attend sa clinic. And then another text message will be to inform them that we implement testing in the clinic. And then pagka hindi po sumasagot yung mga patient, we call them. Okay, then patient screening. Halimbawa po nakarating na yung patient sa clinic. So of course, temperature check, and then alcohol rub, and then questionnaire. So dito po sa questionnaire, nung unang part ng na nag-open kami ulit, yung patients parang takot po sila sumagot, no? Or hindi sila umaamin doon sa mga symptoms nila. But of course, yung mga staff, I told them na you have to dig deep doon sa pagkuha ng history ng patients. So, no, minsan nahuhuli talaga na nagka-ubo, nagka-fever just the day before. So, kailangan we train our staff na talagang mag-dig dun sa history. But now, patients hindi na masyadong takot sa ganito. They're really honest. Minsan, they would tell us na they were positive a few months ago. Wala na masyadong problema unlike nung nag-start kami. And then ito, testing. So since October last year, we started testing our patients. At first, napakahirap po talaga. Ang hirap mag-test kasi I have to think, kailangan ko siyang balansehin, no? Kasi patients, for sure, ayaw nilang magpa-test, no? Majority of the patients ayaw magpa-test. But then, so I think October, maybe this is still Delta, no? Or pawala na yung Delta. So we decided na mag-test ng patients, of course, para sa safety din ng ibang patients, safety ng staff, safety ng family. So ang hirap, but then ngayon, okay na po. Medyo gusto na ng mga patients. Yung iba nga po, sila na mismo yung gustong magpa-test kasi we try to do 1 week validity ng kanilang rapid antigen test. Some patients gusto pa nila magpa-test kahit na valid pa yung kanilang testing, pumapayag pa rin sila magpa-test. And then, okay, in a study by Feldman et al., so this was published in the Journal of American Dental Association, recent lang, 2022. So 100% ng patients ang sabi nila, does knowing that your dental and office staff regularly tested make you feel safer? So 100% said yes. No? Sabi ng mga patients, they feel safe kapag alam nila yung mga dentist at yung office staff nagtitest. No, kami po, we test once or twice a week. And then 94% ng patients naman, when asked if knowing that all patients are tested make you feel safer when coming for your dental appointment, sabi ng 97%, yes, they feel safe kapag alam nila yung katabi nilang dental chair na may patient din na test din, no? Ito po yung sinasabi ko sa mga patients, no? Kasi some patients are really hesitant to get tested. I don't know why. Siguro ayaw nila. Baka yung false positive, natakot sila. I just tell them, just imagine if we don't test our patients, what if yung katabi mong dental chair, yung nakaupo dun is positive, no? So there's a big chance na mahawa ka rin. So they would realize na tama nga, so they agree to testing na din. So yun, little by little, pumayag na rin mga patients namin. So okay na. So 89.5%, no, ang sabi nila, when asked if you had the choice of going to a dental office where patients and staff are tested or not, 89.5% preferred an office that tested its patients and the clinic personnel. So yun po. And then ito po, napaka-importante din po nito, pre-procedural mouth rinse. So in our clinic, we use three types of mouth rinses. So number one is the povidone iodine. Number two is the chlorhexidine rinse. And then number three is the cetylpridinium chloride. So in an article noong 2020 by Moskowitz and Mendelhoff, so they studied yung 4 na klaseng mouthwashes, including hydrogen peroxide, but kami, we don't use it. So ang sabi so this in vitro laboratory study demonstrated that iodine-based oral rinses have superior antiviral efficacy with no associated cytotoxicity. Their use pre-procedurally will significantly aid in cross-infection in closed dental settings. However, further investigation of their antiviral applications and more studies in clinical settings are needed. So kailangan pa rin ng further testing, but it shows a lot of promise. No? And then next is 2022, no? Published din sa American Dental Association Journal by Silva et al. Using povidone iodine-based solutions as pre-procedural rinse in dental setting appears to be potentially effective in reducing SARS-CoV-2 oral load. There are no powerful arguments to consider using hydrogen peroxide and chlorhexidine effective regarding SARS-CoV-2 virus, and their use as pre-procedural mouthwash aiming to reduce SARS-CoV-2 oral load should be revised. So more tests pa din daw and study, but povidone iodine and CPC-based mouthwashes, they show potential sa load reduction ng COVID. And then 2020 and 2019 studies. So povidone iodine has been suggested to be useful for both oral and nasal disinfection against SARS-CoV-2. Balik po tayo. So PPE gowns, either disposable or washable. So I don't have to elaborate on this kasi alam ko po that every day you wear this in the hospital. Then gloves, syempre, and then masks and respirators, face shields, goggles, and eye covers, and others. So dito po sa screen nito, so may PAPR. Ako po hindi pa ako nakagamit. Dentists are using it. And then, of course, our medical doctors are using it too. For me, and for us in the clinic, our doctors in the clinic, we use this one. Itong white nito, tsaka itong black. This is called the gill mask. What I like about this is yung fit nung soft silicone niya around your face. No? Talagang sealed na sealed yung face mo. And this is also very economical kasi all you do is like, this one right here, this is the filter. You just cut a small portion of your the regular surgical mask, and then ilagay mo siya doon, lock mo, you're ready to use it na. But me, I put another surgical mask on top of it just to protect it from splatters. But then the problem with this one is, ang hirap huminga kasi sealed na sealed nga yung mask dun sa face mo. Then the moisture would accumulate right here. And our pedia dentist, si Dr. Dada, our speaker kanina, so suggested, she did some research and suggested to use the easy flow. So what we did is we cut a hole dito sa may silicone, tapos in-attach namin yung easy flow, and solve na, mas madali nang huminga, and then wala nang accumulation ng moisture. Okay, so I think the gold standard is still yung medical respirators and then yung N95. Okay, equipment. So one of the reasons why natagalan mag-open yung mga clinics ulit is kasi wala pang mga equipment na dumarating. No? So may karoon ng shortage na sa equipment or hindi alam kung anong klaseng equipment pa yung kailangan para sa clinic. So number one is the high volume evacuator. This is a high volume saliva ejector, malakas po siya. And then extra oral suction machine, air purifiers, among others. So ang recommendation po talaga is negative pressure room. But the thing is, not all dental clinics, possible po magkaroon ng negative pressure room. Alam niyo po, I contacted an engineering company na gumagawa ng ganito negative pressure rooms, no? Basta kompleto, clean air coming in, dirty air going out. They quoted sa clinic ko, I think 800,000 pesos to make the room a negative pressure room. So medyo hindi possible. So ang sabi ng isang article, if it's not possible, just use sufficient ventilation to diffuse the viral load. So, okay, ito po yung mga equipment natin. So this one on the left of the screen, this is the high volume evacuator. No? Malakas po siyang saliva ejector. So kasi ayaw natin mag-pull yung water at yung saliva sa mouth dahil baka mag-gag yung patient, baka maubo. So kakalat yung saliva, yung aerosol, yung splatter, ayaw po natin yan. And then this one in the middle and on the right side, this is the extraoral aerosol suction machine. So, ito po. So I'll show you a video of the extraoral machine, aerosol suction machine. Ito po, hindi pa po naka-on. They're performing a cleaning on the tummy.
3, 2, 1.
So, on na po yung splatter. That.
3, 2, 1.
So once it's completely off, you see aerosols flying in. So yun po yung, just imagine kung magtutuloy-tuloy po yung yung pagkalat po ng aerosol doon sa room. Okay, so another article, September 2021, characterization and mitigation of aerosols and spatters from ultrasonic scalers. Ultrasonic scalers po is yung ginagamit po for cleaning. So ang sabi po dito is use of saliva ejector and high volume evacuator resulted in overall reductions of 63% and 88% respectively. Whereas an extraoral local extractor, ito po yung aerosol suction machine, resulted in a reduction of 96% at nominal design flow setting. Just imagine if you could reduce the aerosols by 96%. So napakalaking bagay po nun. And then disinfection and sterilization. So in between patients, we disinfect our chairs. So we use disinfectant spray. This is disinfectant wipes. Change plastic barriers sa control panels. Then hand pieces and scalers would be soaked and sterilized. Reception area. So naka-wipe din yung mga seats. And then we mop the floor with solution ng sodium hypochlorite, door handles and doorknobs. Regularly disinfected din po. And then after work, sa afternoon, pauwi na yung lahat. So we use UV light sterilization in all treatment areas and reception areas. So this is what we use. So 30 minutes. And then again, of course, all instruments will have to be sterilized using individual pouches and then put in autoclave. So the next day they're dry, they're ready to use. Okay, conclusion. So alam po natin na yung characteristics po ng COVID, no? Sobrang transmissible po siya. So it makes dentists and all healthcare workers highly exposed to the risk of infection. Then testing, efficient sanitizing procedures combined with correct use of PPE, proper equipment, pre-procedural mouth rinses can significantly reduce the probability of SARS-CoV-2 being transmitted during dental practice. Social distancing, dental office, clinic rooms, instrument sterilization, surface sanitizing protocols can reduce the risk of spreading SARS-CoV-2 but not preventing it. So, this is my prayer for all of you. So before I end my presentation, so dear friend, I hope all is well with you and that you are as healthy in body as you are strong in spirit. 3 John 2. So again, thank you po sa Olongapo Medical Society for inviting us. God bless po. Keep safe. Thank you.
Thank you, Dr. Ong. So I will remind everyone again, if there are questions, you may type them down sa chat box natin and we will answer them at the end of the 3rd lecture. So our 3rd lecturer
Doon. Kahit tayo, Maron.
So our third lecturer is Dr. Marvin Tolentino with his lecture titled Oral Cancer. Quick background of Dr. Tolentino: graduated Doctor of Medicine at the University of Santo Tomas, had his residency training in otorhinolaryngology, head and neck surgery in East Avenue Medical Center, fellowship training in craniomaxillofacial surgery, University of Freiburg, Germany, diplomate of the Philippine Board of Otolaryngology, head and neck surgery, fellow of the Philippine Society of Otolaryngology, head and neck surgery. Clinic and affiliation. His clinic is located inside the Redon St. Jude Medical Arts Building. He is also affiliated with the following hospitals: Redon St. Jude Medical Center, James L. Gordon Memorial Hospital, and Bataan General Hospital and Medical Center. So, Dr. Tolentino.
Thank you, Doc Maron, for that wonderful introduction.
Yes, Doc, you can share your screen now.
Good evening. At first, habang ginagawa ko itong slides ko, iniisip ko yung objectives ng session na ito. Pero I thought of a better objective that would be my goal. The goal of this session is to prevent everyone from having oral cavity carcinoma. Sana matuto tayo paano ito gawin. Babala po at paumanhin na lang sa mga kumakain. May mga masasela na larawan. The oral cavity extends from the cutaneous vermilion junction of the lip to the anterior tonsillar pillars. So mula dito hanggang doon sa likod. The posterior border of the oral cavity also includes the circumvallate papillae inferiorly and the junction of the hard and soft palate superiorly. So dito naman sa baba, inferiorly and then superiorly dun sa taas. Anterior would be the soft palate and posterior would be the soft palate. The oral cavity is divided into 7 anatomic subsites. The lips, the oral tongue, which is only the anterior 2/3 is included, the floor of the mouth, the buccal mucosa or inner cheek. This is a paired anatomy. The gingiva, we have the superior and the inferior area. The retromoral trigone, we have the right and left. This one and this one. And the hard palate. To aid us in the diagnosis of oral cavity carcinoma, we must learn to distinguish them from the others. Obtuse ulcer is a white spot with erythematous halo on a non-keratinizing mucosa, often triggered by local trauma, usually resolves within 7 to 10 days. Ito yung tinatawag natin na singaw. Minsan rhomboid glossitis. This is a smooth reddish area of the midline of the tongue, devoid of papillae. sometimes with a corresponding lesion along the hard palate, may be associated with candida overgrowth. Fordyce granules. This is a painless pinpoint yellow nodules that occur bilaterally on the posterior buccal mucosa and result from enlargement of ectopic sebaceous glands. Hairy tongue involves hyperplasia of filiform papillae that may be black, blue, brown, or white, depending on the microflora and nicotine staining. This is a temporary condition which is often associated with candida overgrowth and usually resolves with proper oral hygiene. Epulis is a non-specific term for tumor-like masses of the gingiva. Epulis is associated with pregnancy. Other term is pyogenic granulomas. Treatment is by excision and curettage of any underlying bony defect. Granula is a mucocele of the sublingual gland that presents in the floor of the mouth. Plunging granula penetrates the mylohyoid muscle and presents as a soft submental neck mass. Excision should include the entire sublingual gland in order to prevent recurrence. Necrotizing cyalometaplasia is a benign ulcerous lesion on the posterior hard palate caused by trauma to the minor salivary glands. Lesions usually heal within 6 to 10 weeks. Torus palatinus, if it is found in the palate. We call it torus mandibularis if it is found in the mandible area. It's a benign excessive bone overgrowth in the midline of the palate that continues to enlarge beyond puberty. Occasionally, it must be removed to prevent denture irritation. The most common premalignant oral lesions, the leukoplakia, erythroplakia, and lichen planus. Leukoplakia, this is a white hyperkeratotic lesion that may or may not be associated with dysplastic changes on histologic examination. Occurs most frequently on the lip. Less than 10% of isolated leukoplakia will prove to be carcinoma or severe dysplasia on biopsy. Erythroplakia. Granular erythroplakia area, erythematous area, often encountered in association with leukoplakia. Half of these lesions demonstrate severe dysplasia or carcinoma in situ on biopsy. Erythroplakia is the most common presentation of early squamous cell carcinoma. Mas malala pa ito kaysa leukoplakia. Nodular leukoplakia has greater malignant potential than isolated leukoplakia, with risk similar to that of erythroplakia may be seen in association with frank invasive cancer. Oral lichen planus is a chronic condition. There is no cure, so the treatment focuses on helping severe lesions heal and reducing pain or other discomforts. What could have been the cause of those previously described lesions? Cigarette smoking, tobacco, alcohol exposure, betel nut chewing, frequent trauma, and human papilloma virus has emerged as a risk factor. A recent meta-analysis of 52 studies revealed a pooled HPV DNA prevalence of 22.5% in oral premalignant disorders. How do we treat? Either we stop the exposure or excise for biopsy. Now we go to oral cavity cancer. Same. Pareho lang din. Tobacco use, alcohol use, ito, HPV. But how do we get human papilloma virus infection? This would be secondary to sexual activity, including oral sex with someone who has HPV, and is the most common way someone gets human papillomavirus. Excessive sun exposure to the lips is also a causative, is also a cause of oral carcinoma. Again, with emphasis on using tobacco, is a single largest risk factor for head and neck cancer. Secondhand smoke may also increase a person's risk of head and neck cancer. Combined use of tobacco and alcohol has a multiplicative rather than an additive effect, resulting in a 15-fold increased risk for developing these cancers. Men are more likely to develop cancer, which is 1 in 60 and 1 in 140 for women. Fair skin is linked to a higher risk of lip cancer. So Caucasians and East Asians, yung mga mapuputi. People older than 45 have an increased risk for oral cancer, although this type of cancer can develop in people of any age. Poor oral hygiene, lack of dental care, and not following regular oral hygiene practices may cause an increased risk of oral cavity cancer. Siguro ibig sabihin nito, hindi sila nagtututbrush. Poor dental health or ongoing irritation from poorly fitting dentures, especially in people who use alcohol and tobacco products, may contribute to an increased risk of oral cancer. Poor nutrition, a diet low in fruits and vegetables, and a vitamin A deficiency may increase the risk of cancer. Chewing betel nuts is a nut containing a mild stimulant that is popular in Asia. Also raises a personal risk. People with a weakened immune system may have a higher risk of developing oral and oropharyngeal cancer. Marijuana use is also a risk factor. After the cause, now we go to the complaints of the patients. A lip or mouth sore that does not heal, a white or red patch on the gums, tongue, or lining of the mouth, a lump on the lip or in the mouth, unusual bleeding, pain or numbness in the mouth area. Also a swelling of the jaw or neck, pain in the ear, pain or difficulty swallowing or chewing, and unintentional weight loss. So, how is oral cavity cancer diagnosed? Your dentist knows what a healthy mouth should look like and probably has the best chance of spotting any cancer. Take note, as part of your routine dental exam, your dentist will conduct an oral cancer screening exam. Experts recommend getting checked every year starting at age 18 and sooner if you start smoking or having sex. This is ideal, but what usually happens is the ENT sees the cases first. It is seen not in a suspicious way, but a frank manner of presentation. Ayan, malalaki na kapag dumating sa amin yung mga bukol nila. Malignancy is confirmed by histologic evaluation of a tissue biopsy. So, for the primary site, nag-wedge kami nito, wedge biopsy, incision biopsy, or excision biopsy. And cytologic evaluation of a fine needle aspirate from an enlarged lymph node. Next is a CT scan or MRI of the soft tissue of the neck, which defines the size and location of the primary tumor, and involvement of surrounding anatomical structures and lymph nodes. MRI is preferred for nasopharyngeal, sinonasal, skull-base, and sometimes small oropharyngeal tumors. Chest imaging by X-ray or CT is important for identifying distant metastases or a primary lung cancer. For patients who may require radiation therapy, the need for dental care should be evaluated by dental X-rays and consultation with the dentist. Any necessary dental work should be performed prior to radiation to reduce risk of osteonecrosis. Malignancy of the oral cavity. There were 396,000 cases of cancer of oral cavity and pharynx, accounting for 3.7% of all cancers. The oral cancer is the 8th leading type. This 2021, we registered a 54,000 of new cases. Again, it's a male predilection type of cancer. 145 new cases each day is being recorded. 10,000 deaths every year. That makes up about 1.8%. This explains why it has a predilection in older patients because of frequent and chronic exposure. So pag bata pa, hindi gaano na-expose, pero habang tumatanda, mas matagal ng exposure, mas magkakaroon ng cancer. Although more common at age of 40s and up, it is also seen in the younger age. The site distribution or predilection. This is data in the US. So it is most and more common in the tongue. Next would be the buccal mucosa, then gingiva, and then palate. And this, in comparison with our data, the first data was gathered in 2009, and the second one is in 2020. If we analyze this, the most common is the mouth, not the tongue. But probably in this study, it included the other subsites of the oral cavity in the mouth, namely floor of the mouth, retromolar trigon, buccal mucosa, and the hard palate. So it's a cumulative data of the mouth cancer. If we now we can say that it is more common in the tongue. So it jives with the data of the US and the Philippines. What is the most common malignancy of the oral cavity? Still, it's a squamous cell carcinoma. 80% of all oral cancer cases. This cancer is derived from the lining of the oral mucosa. Once a diagnosis is made, the cancer is staged before a treatment plan is established. T is for size of tumor. N is the presence and size of lymph nodes. And M, which is not present here, but part of the T and M, is evaluation for metastasis. This is a global recognized standard for classifying the extent of spread of cancer. This staging provides a useful estimation of prognosis, aids in treatment selection, and permits the assessment of treatment outcomes. The American Joint Committee for Cancer, we call it AJCC, coordinates and periodically updates the criteria for assessing the staging. This is done or determined by physical examination and imaging. The Roman numerals represent the stages, like in Roman numeral number 1, here encompasses T1 and N0. When we say T2, with no nodes, that's stage 2, and so on and so forth. Oral cancer is treated the same way many other cancers are treated. It could be a stage-dependent treatment. It could be excision or extirpation alone, or with reconstruction. The patient may need only one type of treatment or may need a combination of treatments. Recommendations are usually made after consultation among the multidisciplinary team of oncologists that includes or composed of the head and neck surgeons, the radio-oncologists, and the medical oncologists. Most patients' death with head and neck cancer is as a result of local or regional failure. Therefore, after definitive treatment, regular follow-up examinations are crucial. When recurrence is identified, early salvage therapy may be effective. Second, primary cancer remains constant at about 4 to 5% per year. Routine tumor surveillance visits should be performed every 6 to 12 months for life. Follow-up intervals are not standardized. Recurrences usually present in the first 2 years after treatment. So a head and neck examination may be performed every 4 to 6 weeks during the first year and every 3 months during the second year. During years 3 to 5 years, follow-up may continue at 4 to 6 month intervals. Pain is a sensitive indicator for tumor recurrence and should serve as a warning sign for the head and neck oncologist. Distant metastasis develops in approximately 15% of patients along the course of the disease and treatment. Distant metastases also present at diagnosis in 5 to 7%. Screening for presence of distant metastases may include plain chest X-rays, chest CT scan, or PET scan, CT scan, depending on the presumed risk and treating center. Now let's see, how do these cancers look like grossly? This is the carcinoma of the tongue. Most commonly arises from the lateral tongue area. As I have said a while ago, that combined use of tobacco and alcohol has a multiplicative rather than an additive effect, resulting in a 15-fold increased risk for developing these cancers. Carcinoma of the lip, 90% of which is a squamous cell carcinoma, secondary to excessive sun exposure and tobacco use. This is the third most common oral cavity cancer, carcinoma of the floor of the mouth. Carcinoma of the retromolar trigone. At presentation, regional metastases are common in 10 to 20%. True incidence of retromolar trigone carcinoma is difficult because tumors affecting the trigone often involves adjacent sites. Carcinoma of the alveolar ridge, gingival mucosa. Most commonly arise in the dentulous areas or at free margins of the lower alveolar ridge. This is caused by chronic irritation and inflammation of gingiva over a period of several years due to calculus formation and collection of microorganisms. Carcinoma of the hard palate. Only half of all tumors are squamous cell carcinoma. The rest would be minor salivary gland tumors. Can be confused also with necrotizing cyalometaplasia. This is a benign mucosal inflammatory lesion. Carcinoma of the buccal mucosa. This is less than 10% of all oral cavity carcinoma. Dentists are typically the first to notice signs of inner cheek cancer, often during a routine dental exam. What is the outlook for people with oral cancer? This is at a glance different from the AJCC staging. This is surveillance epidemiology and results. This is another way to evaluate and stage the patient. The overall 5-year survival rate for patients with an early diagnosis of oral cavity and pharynx cancer is 84%. If the cancer has spread to nearby tissues, organs, or lymph nodes, the 5-year survival rate drops to 65%. Prevention of oral cancer. Primary prevention would be prevent cancer from happening. Secondary prevention is prevent it from spreading or getting worse. The tertiary prevention would be prevent the patient from dying. The primary prevention focuses on avoidance of known etiological factors and healthy lifestyle choices to prevent cancer development in the first place. This is particularly important because oral cancer is one of the few cancers with a high potential for prevention. Pero hindi ko pa rin maintindihan. Itinuturo na sa school na kahit sa advertisement, smoking is dangerous to your health. Tinaas na ang price ng sigarilyo at saka alak. Nagpatong ng maraming buwis, wala pa rin. Advertisement bans, wala pa rin. Kasi wala nang advertisement sa TV, kahit sa mga sari-sari store, natanggal na rin yung mga advertisement ng sigarilyo. Wala pa rin, pero madami pa rin naninigarilyo at umiinom ng alak. Kaya pag minsan sabi ko, bakit kaya? Ano kaya nangyayari dito? Reducing your risk for HPV infection is also important. HPV vaccination for young boys and girls. We were taught before in med school that HPV vaccination is better to be given in young boys and girls, but not in older ones who are already active in sex. This is already secondary prevention. Ayaw sana natin ito, pero the earlier the better. You can take an active role in detecting oral cancer early, should it occur, by doing the following. Conduct a self-exam at least once a month. Hindi na kailangan i-memorize yan. Silipin lang natin yung bibig natin sa salamin, ilawan natin, at kapain natin. Ang liit naman yung area para ma-check natin lagi. See your dentist on a regular schedule. Even though you may be conducting frequent self-exams, sometimes dangerous spots or sores in the mouth can be very tiny and difficult to see on your own. The American Cancer Society recommends oral cancer screening exams every 3 years for persons over age 20 and annually for those over age 40. During your next dental appointment, ask your dentist to perform an oral exam. Early detection can improve the chance of successful treatment, but prevention is better than cure. Questions you can ask to your doctor. Pag minsan hindi na rin alam ng patient kasi nabibigla sila kung ano yung tatanong nila. So, nagdudual ako pag minsan kung anong klaseng cancer meron sila, yun yung kinukwento ko sa kanila. At saka kung anong ibig sabihin nun, at saka kung hanggang saan na siya umabot. You may take a screenshot of this slide. Ang haba, ang dami. During treatment, ito na rin, mahaba din. After treatment. Pero sa akin, nagdudwell ako sa kwento ko sa kanila. So ito yung kinukwento ko sa kanila. What's the survival rate? What's the quality of life during and after the treatment? And ito naman yung pinaka-importante, lalo na sa atin dito sa Olongapo. Is there anyone who could help me if I cannot afford the treatment? Of course, meron. Madami. Wala nga lang dito sa Olongapo. Meron tayo sa San Fernando, yung Jose Bilingad, and marami sa Manila. Meron yung dito naman sa Bataan, inuumpisahan pa lang yung Bataan General Hospital. And to end this lecture, different factors cause different types of cancer. Researchers continue to look into what factors cause oral and oropharyngeal cancers, including ways to prevent it. Although there is no proven way to completely prevent this disease, you may be able to lower your risk. Several of the risk factors for oral and oropharyngeal cancers can be avoided by making healthy lifestyle choices. Early detection can improve the chance of successful treatment, but prevention is still better than cure. And this would be my last slide. Thank you for listening.
Thank you, Dr. Tolentino. And I would like to thank all our speakers for today for your very wonderful lectures. Now we're going to accommodate your questions written in our chat box. So first question for Dr. Eustaquio.
Doc, Dada na lang, Doc. Mas ang hirap i-pronounce ng name ko.
Ito ba?
Doc, Dada na
Dada.
lang. Yes.
So this question is from Dr. Lyson. My granddaughter is 2 years old. I help her brush her teeth before bedtime. She loves the taste of toothpaste, and she ends up eating the toothpaste more than she brushes her teeth. Is that bad?
Doc, as long as, diba, I said, of the right amount, same lang din with our medications, even with multivitamins din natin, no? So, this is what, like, you check the label po, no? So, if it's a 1,000 to 1,450 ppm, but this is what I don't like with kiddie toothpaste, no? They're sweet, eh. But the more na gustong lunukin ng patient yung toothpaste. And also, with my son po at 6 months, kasi by 6 months natangipin na po siya, pero kahit anong pray ko, sana 1-year-old siya matangipin, pero binigay sa akin ng 6. He has been using an adult toothpaste ever since po na nagtangipin siya. So why I like using an adult toothpaste? Kasi po, diba, ang adult toothpaste natin, they're minty. So what happens is that, matitrain mo yung kid na, oh, that minty feeling is equivalent to clean. Unlike if it's kiddie toothpaste, sweet siya. So, syempre, yung mga gusto niyang kainin na candies, sweet din siya. So, walang parang line to say na, oh, this is not really good na lagi mo pinakain. But in terms of the toothpaste po, as long as, Doc, na okay tayo, yung amount na nilalagay ninyo, wala naman po tayo problem. Magiging problem ang yung fluoride natin if, let's say, like yung isang tube kinain niya, then definitely medyo matatakot po ako kasi sasakit yung tiyan niya or pwedeng itakbo na natin sa hospital pag nangyari po yun, no? But then, as long as tama, konti naman po yung nilalagay natin, appropriate for her age, then okay lang naman po yun. Yung anak ko din, kahit minti minsan, parang pag naglalaro siya sa akin, nalulunok po din niya. Now kasi nga po, hanggang ngayon nakahiga pa rin kami mag-brush. Tapos eventually, sabihin niya, Mami, ako. So pupunta kami sa banyo, doon siya magtutoothbrush. So yung higa namin na ako nagbabrush, nalulunok pa rin po niya yan. Pero of that, P-size po yung ginagamit ko na po kasi sa kanya.
Okay, thank you, Doctora, for that very wonderful answer. So another question from Dr. Rachel Caseja. I think this is also for you, Doc. Doc Daga.
Para sa akin nung ano. So,
Marami
with the
sunod-sunod.
yung sa intubated, Doc, no? Kasi diba, what yung common na nagiging problem with critically ill patients are yung ventilator na associated pneumonia. So, kung kaya sana natin, of course, we still clean the mouth of our patients. So, Doc, diba, like I said, use a small-headed toothbrush, or kung talagang mahirap, yung swab na yung sa swab na sponge. So, let me just share lang, Doc, no? Let me just share what the toothbrush that I recommend with my special needs patients is. Ito po, no? So this is yung compact top or TP. Very, very small po siya. Even with my son, and up until now, even me, I still use it po, no? Kasi may areas na ang hirap talaga i-reach. Even yung mga may wisdom tooth na ang hirap i-abot. This is what I recommend even with my special needs patients po. So, I'll just move here a little bit, no? So it is TP na compact top. Yun lang, it's a bit hard to find this toothbrush. Hindi mo siya makikita basta sa market. With our clinic, we offer this to our patients po, no? If not, pwede po yung, kung mahirap, then, cannot find, then yung mga oral sponges, which is very common po sa hospital to, no? You can use that. And of course, let's not forget yung suction. Because we don't want any bacteria, kasi mag-accumulate yung bacteria inside the mouth po niya. So when we intubate the patient, well, when you intubate the patient, possible that the bacteria masasama din because of the respiratory po yung maapektuhan natin. No? So, yes pa rin po, yun lang, dagdag talaga trabaho on the nurse or kung sino man yung pinaka main na caregiver po ng patient natin.
Thank you, Doctora. So, Dr. Tolentino and Dr. Ong, would you like to share your thoughts about that question? Dr. Tolentino, nakamute po kayo.
Sorry, Dr. Aaron, can you repeat the question again?
Yung about sa oral health, oral care ng intubated patients.
Usually sa ICU, hindi common yung paglilinis nila, pero ang madalas kasi ginagamit nila ay suctioning lang, ano. So hindi ko nakikita yung ginagawa nila nagtutoothbrush sila. Pero pag minsan kapag in-instruct ng doctor ng oral care, so ginagawa ng mga nurses naman yung mga yon. Pero mahirap kasi naiipit talaga, tapos anchored na yung endotracheal tube. So may site talaga na hindi malilinis. Nalilinis sila dahil doon sa mga suctioning na ginagawa ng mga nurses. Pero yung brushing, hindi siya nalilinis through brushing. Siguro, pwede natin gawin yon sa mga hospitals na introduce natin yung oral care sa mga admitted patients natin sa mga ICU.
Ano lang talaga, Doc, no? We minimize the bacterial count inside the mouth talaga. It's really hard kasi I remember I had a patient and I had to remove the brackets kasi for MRI yung patient, so we had to remove the brackets. Hirap na hirap talaga ako ang dumi na nga niya, ang dami pang brackets na isipin yung buong 20, yung lahat talaga ng ngipin niya. So, ang liliit pa ng brackets na yan. So, talagang parang, it's really hard. Kaya, what we want lang is to minimize the bacterial count so that we can prevent the VAP po.
Okay, thank you, Doctor. So, another question for Dr. Ong. This question is from Dr. RJ Manzo. So, is it advisable nowadays to regularly gargle with iodine containing mouthwash as prophylaxis for COVID? Is there a risk for discoloration of teeth for long-term use of such products?
For povidone iodine, wala pa akong narinig sa mga lectures or nabasa sa articles na they can cause staining. Unlike chlorhexidine, it can stain your teeth. No? So for chlorhexidine, ang maximum use yan is 2 weeks lang eh. Then your teeth get some stained na brown or sometimes reddish stain. But for povidone iodine, wala pa akong narinig. But my concern is kung gagamitin mo siyang prophylactic as for COVID is the alcohol content in the mouthwash. I think it contains some 10% alcohol or maybe less. It dries up your throat and the mouth. Yun ang pinaka-concern ko doon. So what I do is, for me, hindi naman everyday na ginagawa kong mouthwash yung povidone iodine. Siguro every 3 days I use it, or pagka medyo alam kong hindi maganda yung pakiramdam ko, hindi naman masama. Basta I feel that I need to do a gargle. Pag feeling ko may risk ako ng exposure, I use it. But then, pag madalas, I feel na dry yung mouth ko, tsaka parang meron akong post-nasal drip. So yun ang napapansin kong side effect sa akin.
Thank you, Dr. Ong. So another question from Doc R. Manzo. Our sons are aged 5 and 11. I think this is for Dr. Eustaquio. Dr. Dada, sorry. Our sons are aged 5 and 11. They like gargling with our alcohol-free mouthwash after they brush their teeth. Is that an acceptable practice for kids?
That mouthwash, doc, does it have fluoride? Most of the time kasi the mouthwash ng fluoride is, if I remember it correctly, nasa 600 to 800 ppm lang. So again, not enough pa rin po siya. But in comparison to water na wala talaga, kasi hindi naman fluoridated yung water natin here, except some parts of Cavite. Medyo parang mas gusto ko siya na at least may fluoride pa rin, but still not enough. The mouthwash, I recommend them actually if, let's say, like lunchtime, hindi siya nakapag-toothbrush, or snack time, then you can have him gargle that one. So it's really an adjunct lang talaga siya. Not necessarily like 100% makakatulong talaga siya. Kumbaga pandagdag lang if case hindi ka makapag-toothbrush. Even with us naman adults, when my patients ask for the parents, I tell them it's an adjunct lang. I would prefer brushing talaga because we really want to remove that plaque. Kasi yung plaque na yan yung kumpol na siya ng bacteria, So we want to remove them as much as we can. So for the mouthwash, pwede naman po siya if, let's say, yan, snack time, pero hindi siya pwedeng ipalit as toothbrush.
Okay, thank you, Dr. La. So another question for both Dr. Ong and Dr. Dada. So do you recommend electric toothbrush? This question is from Dr. David Calapatia.
So, kayo doc muna, Doc Ong.
Ako po, personally, I've been using electric toothbrush since 1998. So iba talaga yung difference, iba yung feeling kapag naka-electric toothbrush ka. Halimbawa, nasiraan ako ng electric toothbrush, so maybe for a week, nag-manual ako. So you feel the difference, no? Parang hindi mo natatanggal lahat yung plaque, yung material ba dun sa surface ng teeth mo. Kaya ever since talaga, for more than 20 years, electric toothbrush na yung ginagamit ko. Doc Dada.
For me naman kasi, there are studies kasi na they would say electric toothbrush would mas beneficiary siya. For my patients, what I notice kasi, even if it's a manual toothbrush, sometimes it doesn't move. Like different kinds of manual toothbrush. It's not really one size fits all din eh, even with the electric toothbrush. So like for example, with my brother, he actually had, nothing against with the brands po, ha? He had Oral-B. It didn't work with him na Oral-B na electric toothbrush. But when I asked him, oh sige, let's try another one, pero very expensive, which is Sonicare from Philips. With that, it really worked with him. Manual, talagang laging hindi niya mabrush ng maigi, nag-aaway kami. Oral-B, ayaw, hindi din niya ma-brush maigi. But with Sonicare, he was able to brush it really well. So, I guess, depende on the case-to-case basis talaga siya. So, parang trial and error yung dating for me. Me, I personally use an manual toothbrush kasi I really like the small-headed na literal na small siya. So, partner ko si Compacta lagi sa banyo ko.
Thank you, Doc. So another question for Dr. Marvin Tolentino. So for head and neck cancer, do you routinely request to rule out possible HPV infection as causative agents if your patient presents with an oral lesion? Do you suggest giving a vaccine?
Dalawa yung question, ano? Una, we don't routinely request to identify if the causative agent is an HPV infection. Sobrang expensive kasi yung diagnostic nun. It's a immunostaining na yung gagawin mo para mag-zero in ka para malaman mo na meron pa lang siyang previous HPV infection. Probably ang causative agent ng cancer niya ay HPV infection. It's about 5,000 pesos yun. Tapos, pag nalaman mo din, yung prognosis lang ang malalaman mo. So, at this point, ang usage lang ng HPV na diagnostic, which is the P16, kung ito ay immunostained, ay just to prognosticate the patient. Better prognosis kapag positive ng HPV, and poor prognosis kapag negative ng HPV. And yung second ay yung vaccination for oral lesion kapag meron na. I think mas maganda kung i-refer kita doon sa better na specialization. Pero dati sa med school, sinabi sa amin, we were taught na kapag yung HPV ay maganda mag-vaccinate sa younger kids. Sa bata, age hanggang 14, yung babae, pati yung lalaki, bago sila maging sexually active. Kapag sexually active na, maninigate na yung pagbibigay ng vaccination. So better siguro, wala pang ginagawa ang ENT na mag-vaccinate ng mga patients. Unlike yung OB na nag-vaccinate na sila dahil doon sa cervical carcinoma. Kaya nagawa yung vaccination na yun because of that cervical carcinoma.
Thanks, Doc. So another question for Doc Dada. This question is from Dr. Malu Pabini. I have a special child as grandson. He's now 12 years old, and it's really our problem how to bring him to the dentist. During the past years, we noticed that some of his milk teeth were being pulled by him. Now we noticed that some of his teeth had already some cracks and decayed. We don't know where to bring him. Is he going to be hospitalized in case of tooth extraction? In that case, where can you refer us? Thank you.
Hindi ko masabi refer to me. Pero with that age kasi, Doc, talagang yan yung age na nagtatanggalan. Actually, yan ang halos pawala na yung matatanggal niyang ngipin kasi he's already 12, no? Most of my patients at 12, panay halos permanent teeth na on that age. So, with with autism po kasi, no, we prefer, me personally lang, I prefer na parang masanay muna siya on the yung place, no, with the clinic. So you bring him to the clinic, no. Like I said, as much as possible, sana wag tayo mag-sedate. There are patients with autism po na na-extract naman namin na without the sedation po, no? So, yun lang, minsan pa isa-isa or dalawang ngipin lang po. Tapos makikita mo naman cooperative pa rin po yung bata. Yes, you would hear them, kasi even us naman, di ba, pag nabubunutan tayo, tapos anxious tayo, mapapaganon din po tayo, no? So, if makita ko naman yung ngipin niya na sobrang multiple dental caries talaga siya, then maybe it would be beneficiary for the patient. Tapos hindi din siya yung behavior niya nasa negative side na po, no? Then maybe sedation would be beneficiary for the patient. So what kind of sedation, doc? So it depends, pwedeng oral sedation. So we have yung dormicum, no? We mix it with chocolate or didikdikin namin then give to the patient. Pero mild sedation lang siya. There are cases na moderate sedation tayo. I am IV clinic setup na I have a partner anesthesiologist po doon. We sedate the patient. We do all the treatment in the clinic po. Or pwede din pong general anesthesia. So it depends actually po kasi kung ano yung kumbaga patient, yung pagpili ng patient po, no? So most of the time, nagpo-fall po ako with my patients na ganyan po is BMT or behavior management, so no sedation at all, or oral or IMIV sedation. Depends on how many cases nung gagawin kung talagang mahirap po yung extraction, maraming extraction yung gagawin. But as much as possible sana, we don't want the patient still sedated kasi bata pa po siya, no? The chances of him being sedated is more than us adults. So, you can refer po sa clinic ni Dr. Ong, nasa Smile Concepts po. Pwede natin po siyang makita doon para mas ma-diagnose po natin ng properly.
Okay, thank you, Doc Dada. So another question for Dr. Ong. This is from Dr. Paulo Villarreal. I would like to ask, are you familiar with misting or ionized water or super oxidized water like anolite over the nasal and oral area for disinfection? What is your opinion regarding this?
I am Dr. Good evening. Thank you for your question. Doc, not really that familiar. Although narinig ko na siya before, ginagamit sa misting and as a surface disinfectant, pero I'm not familiar na ginagamit siya over the nasal and oral cavity.
Thank you, Doc. So for Dr. Marvin Tolentino, question is from Dr. Paulo Villarreal. My question is, what is your take on vaporizers as alternatives to cigarettes and vaping? Do they still pose a significant risk for oral cancer?
Wala pang data ngayon about oral cancer, pero meron ng mga reported na data about sa blood circulation, mga ganun sa heart. Pero about cancer, wala pa. Pero if you take the idea parang heat, parang cigarette pa rin, tapos mas mataas naman yung heat na binibigay nito. So ibig sabihin mas dangerous siya. So pag tumatama yung yung vapor doon sa lungs, tulad nung yung mucosa ng lungs, 'di ba, yung nadi-disrupt sa sa cigarette smoking. Parang ganun din. So mas worse siya, I think.
And Doc, another question po. So is there a specific number of days for a non-healing mouth sore before you should start suspecting a possible oral cavity malignancy?
Just like any infection, meron yung isang pinakita ko kanina, yung minor salivary gland na infection would last about 6 weeks, more than 6 weeks pa. Pero just like any other infection, nagbibigay tayo ng leeway. 2 weeks to 1 month. More than a month, kailangan mag-isip ka na ng iba na. Kung tapos pwedeng i-treat mo siya ng excision or i-disrupt mo yung mucosa with cautery or any chemicals. Pero iisipin mo na on the 3rd or 4th week, kailangan meron ka ng plan to do biopsy.
Okay, thank you, Doc. Our next question is from Dr. Acaseja. So this question is for both our dentists. So what is your take on this question? Our usual practice is we use Bactidol mouthwash as solution. Is it proper or do we need you use the toothpaste?
Solution for the critically ill, mga intubated patients ba yun, Doc?
Yes.
Like with Dr. Tolentino said, no, parang as much as we can, we try to minimize po siya, no. So if let's say ang available din natin there is the yung Bactidol or chlorhexidine, then use it na lang po. But I would prefer pa rin we remove yung, kumbaga kasi I think with yung sponge kasi gagamitin hindi malayo doon, no. Hindi pa rin siya ganong ganda magtanggal ng plaque. So I would prefer pa rin toothbrush. But I understand even with my friends who are in hospital setup, nahihirapan daw. Ang hirap gawin yung parang the ideal na toothbrush talaga, no? So kung kaya, like if you can use the Bactidol or the chlorhexidine, but then again, chlorhex, good for 2 weeks lang po siya, diba? Clean as much as we can, minimize the bacterial count as much as we can para for the maiwasan natin yung VAT po.
Dr. Ong?
Yeah, I would suggest po, if possible, no, if you could use a tongue scraper, so it will help a lot kasi niipon yung bacteria dun sa tongue. Tongue scraper, scrape niyo siya, makikita niyo na maraming matatanggal na dumi doon sa patient.
Okay, thank you, doctors. Another question from Dr. Maricel Ridon. This is for Dr. Dada. When is the best age to start brushing children's teeth? And what recommended toothpaste to use?
With my son, Doc, parang newborn pa lang siya, minamassage ko na yung gums niya so that he gets used to may ginagalaw sa bibig, no? So by that time that he reaches 4 to 5 months, syempre irritable na yung gums because naging ngipin na sila, namamassage na siya. So medyo sanay na din, hindi na siya ganun ka-irritable in a sense na makati na nga yung gums ko, may pumapasok pa sa bibig ko na hindi ko maintindihan. So for the brushing per se talaga, as long as the first tooth erupts, you have to brush it already. And like I said, use 1,000 ppm to 1,450 ppm. So most of the time, those are the adult toothpaste already po. If let's say, Doc, I'm not comfortable with the adult toothpaste, there are kiddie toothpaste in the market that is of 1,000 ppm to 1,450 din naman po. You really had to read the labels. Even na adult toothpaste po, diba? May mga no fluoridated po talaga na toothpaste. But I am a pro fluoride. I believe in fluoride. Like any medicine, even water nga po, diba? If there's too much water, bad din po siya. So I think of it like that po sa for fluoride. So adult 1,000 ppm to 1,450 na toothpaste. Pagkatubo po ng baby teeth in terms of brushing per se, but ako ay massage pa rin the gums kahit wala pa ho siyang ngipin para at least the child gets used to the stimulation already ng brushing.
Okay, thank you, Dr. La. So a question from Dr. RJ Manzo. A question for Dr. Ong. What is your take on herbal toothpaste? Are those as effective as regular toothpaste?
Hi, Doc RJ. common kasi is like fluoride toothpaste talaga yung recommended. But in the US, xylitol is really familiar din. Pwede naman po, basta the important thing is yung proper brushing. So basta tama yung pag-brushing mo, there's a big chance na less ang cavity or no cavities for the patient. So kasi ang gusto natin maiwasan yung pag-form ng acid sa mouth natin. So pag dumami yung acid sa mouth, doon na nagkakaroon ng cavity. So less acid, the better.
Thank you, Doc. So another question from Dr. RJ Manzo. For Dr. Marvin Tolentino, are long-standing untreated cavities risk factors for oral cancer?
Yes, this is a risk factor for oral carcinoma. This is secondary to frequent irritation of the gingiva. It would be a risk factor for cancer.
Okay, Doc. So for our dentist, this is from Dr. Armin Mendoza. So may I know your thoughts po on using Debacterol for treating oral sores?
Hello, Doc Armin. Debacterol, really effective for mouth sores, pero napakasakit lang talaga pagka in-apply mo. No? So I remember yung kapatid ko, pag-apply ko ng Debacterol, napatayo sa dental chair. So masakit talaga. The lesion is still there, but yung pain, wala na. No? Side effects, so far, wala akong nakitang side effects for Debacterol. Ewan ko kay Doc Marvin, baka he's familiar with the side effects of Debacterol. But for me, it's really effective. Kahit na
Dr.
gaano
Tolentino.
kalaking mouth sore.
Yung Debacterol, nung nasa residency kami, pupunta ako sa Bambang dati, bumibili ako. Tapos, pag may mga patients kami, nakakita ko mga singaw, mga ganon. Dun sa ina-applyan ko yun, nilalagyan ko. Tama yung sabi ng Dr. Ong. Pero may mga patients din na bumabalik na mas malaki na naman yung niya, yung lesion niya. So mas malala na naman. So hindi lahat eh. So parang case to case siya. Kung ito ay yung Debacterol kasi, so yun yung idea ng yung Debacterol ay di-disrupt mo yung mucosa tapos para mag-regrow yung nasa ilalim. Pag nagawa yon, kung hindi naman siya cancerous, okay lang, walang problema. Pero pag pre-malignant siya, ma-aggravate mo lahat siya. So, case to case, kung antayin na lang natin yung yung healing process niya, tapos yung proper na management. Pero I have nothing against the Debacterol. Kung mag-improve siya, good. Pag hindi, that's the time we do biopsy.
Dr. Tolentino, may question ako. Is it ako yung yung Debacterol ba, Doc? Is it available agad like sa doctors po ba? Kasi like I know with us dentists, we know already kung saan makakakuha nun. With the doctors ba, are they informed about that Debacterol as a whole thing?
Hindi, kasi ang mga ENT residents dati, madalas kami sa doon sa may Quiapo, anong street 'yon? So,
pero yes, Doc.
Oo. Tapos doon namin natututunan lahat yung mga kung ano yung mga secret ng mga dentist. Pero wala kasi wala naman sa FDA, wala naman siyang license doon. So hindi siya binebenta rin sa mga sa Mercury, mga ganon. Pero effective din naman siya.
Share ko lang din po, no? Because
Yeah.
back when I was still a dental student, so yung lola ko kasi nagkasingaw din po siya. So syempre, alam ko kung saan makakakuha, I gave her the small bottle of the Debacterol. Yung pala ginagawa niya, halos everyday, basta lagi siya naglalagay. So by the time na pumunta siya sa doctor niya, ang laki na ng sugat niya. So apparently, nasunog niya ng sobra yung singaw niya. Hindi ko kasi siya nabantayan noon. So yun lang po, parang since with Debacterol, heads up lang din po. Hindi po siya yung parang lagi-lagi siyang ilalagay. With us po, isa, 2 beses lang po. Most of the time, isa nga lang po. Yun nga lang talagang super sakit po.
Can I add more?
Sige.
Tama, ano? Tama yung sinabi mo, yung case-to-case yung debacterol. Kung yung iniisip mo ay singaw, yung aptus, sore, usually I treat that with, ayoko nang, gusto kong ikwento sa lahat kung paano ko tinitreat ito. Kasi baka mamaya, ako yung gagamutin, hindi na alam kung ano yung gagamot sa akin. Simpleng singaw lang pala. Tinitreat ko ito ng vitamin B complex at saka steroids na 1 to 2 days lang. Then magre-resolve siya. On the first day ng high dose na steroids, on the second day makakita mo na yung pain niya about mga 50% na mawawala na. Then vitamin B complex. Yung B complex ay para dun sa wound healing. Yung steroids would be para dun sa inflammation. So i-arrest na inflammation, magre-regrow yung mucosa, mag-heal na yung mucosa. Yun yung idea nun. Pero wala sa studies nun eh. Ang sinasabi nila ay don't use steroids kasi baka ito ay fungal infection. Kaya hindi natin ginagamit yun. Pero very effective sa akin. I have yet to see yung patient na hindi mag-respond doon sa treatment ko na yun.
Thank you, Doc. Follow-up question po. So, is the Bacterol safe to use in children?
Doc Mendoza, ako po pag naglagay ako pag may singaw lang ako, umiiyak na po ako kasi alam ko maglalagay po ako ng Bacterol at super sakit po yun. Hindi po nila natotolerate yun 100%. Most of the time with my patients, if they have singaw, I just tell them, it would heal naman by itself if, let's say, trauma talaga yung case niya. Of course, wag lang nila paglalaroan. And the patients, they don't like it being touched kasi nga, for them, masakit siya. Ayaw nilang galawin. So, kahit magpalagay ng gamot yan, ayaw din nila. So, I just tell them, let it heal by itself. And most of the parents, mas gusto din nila yun kasi di na sila bibili, tapos hahayaan na yun lang. Oobserbahan nila yung kid not to keep on biting on it or touching it po.
Okay, so okay. I'm sorry.
One more.
Yes.
About dun sa kids, yung history and PE doon sa tanungin mo yung merong singaw. So usually mapo-profile mo siya na stressed out siya lately, puyat siya, gano'n. Sa bata naman i-check mo baka merong namamalo siya, pinapalo siya, na-stress siya kung hindi trauma. Pwedeng traumatized din siya eh. Pero usually kasi kahit na traumatized siya, mag-heal ka agad. But hindi nag-heal ka agad, so yung immune system niya mababa. So i-check natin yon. Wag natin ipagbawal ang bahala kapag nagsisingaw ang bata. I-check mo baka merong mental trauma sa kanya. Merong nang bubuli sa kanya. So part 'yun ng evaluation. Thank you. Ay, sorry. Kahit na hindi mo siya gamutin, patulugin mo lang siya ng maaga, in 5 to 7 days, mag-i-improve yan.
So, if I may add po, no? Doc, tama po kayo doon. Usually, patients maraming singaw pag exam week. No? Nung may pasok pa, pag exam week yan, puro marami kang patients nagko-consult na maraming singaw. So for kids, takot akong gamitin sa kanila kasi nga alam ko masakit. So what I usually recommend is a mouthwash na combination ng hyaluronic acid and cetylpyridinium chloride. So yun yung ginagamit ko na pang mouthwash sa mga bata. So, para for faster wound healing din. So yun lang po.
Okay, so that will be our last question for today. So thank you to all our audience, very interactive audience for tonight. So if there are other questions po, you can message our speakers and they will answer your questions po. So to proceed, let's proceed to awarding of our certificates to our speakers. So the Olongapo City Medical Society would like to present this certificate of appreciation to the following. So Dr. Daryl Joy D. Eustaquio for her valuable contribution to the Olongapo City Medical Society's cancer awareness advocacy as a speaker for her lecture entitled Healthy Smiles, Healthy Body, given this 28th of February in the year of our Lord 2022. Signed by the Secretary of the Olongapo City Medical Society, Dr. Arl Manzo, and the President of the Olongapo City Medical Society, Dr. Raymond Joseph Manzo.
Thank you po.
So, next we have this certificate is presented to Dr. Johann Christopher Ong for his valuable contribution to the Olongapo City Medical Society Oral Health Cancer Awareness Advocacy as a speaker for his lecture entitled Safer Dental Visits in the New Normal, given this 28th of February in the year of our Lord. Signed by Secretary of the OCMS, Dr. Arl Manzo, and President of the OCMS, Dr. Raymond Manzo. Dr. Ong.
Thank you so much po. Thank you, doctors. God bless.
So next we have this certificate is presented to Dr. Marvin M. Tolentino for his valuable contribution to the Olongapo City Medical Society's Oral Health and Cancer Awareness Advocacy as a speaker for his lecture entitled Oral Cancer, given this 28th of February in the year of our Lord 2022, signed by Secretary of the OCMS, Dr. Arl Manzo, and President of the OCMS, Dr. Raymond Joseph Manzo. Dr. Tolentino.
Thank you, everyone.
So next po.
Ako naman, Maron. So, in behalf of the Olongapo City Medical Society, we would like to give you this certificate of appreciation to Dr. Maron Ruadap for his valuable contribution to the Olongapo City Medical Society's Oral Health and Cancer Awareness Advocacy as a moderator for the lecture tonight entitled Say Ah, given this 28th of February in the year of our Lord 2022, signed by our Secretary, Dr. Arl Manzo, yours truly as the President. Thank you, Dr. Maron. And I would also like to acknowledge our chair for this activity, Dr. Maricaridon. Thank you for organizing this activity tonight. Thank you.
Thank you, Doc. Thank you.
Thank you po.
Thank you. So for our closing remarks, let's welcome Dr. Jerome Acosta, Olongapo City Medical Society Vice President. Dr.
Thank you
Jerome.
po, Aaron. Yes, thank you po. To Doctors Dada, Dr. Johann, thank you for sharing your valuable time and talent and expertise with the rest of the audience. Dr. Maron, thank you for moderating. At Dr. Ikay, thank you for spearheading this lecture. Dr. Tolentino, my very close friend, ang dami natin natutunan about oral cancers, how to detect, how to prevent them. Very easy, just stay away from alcohol and smoking. So that's the point of the lecture. And for our dentists, we appreciate so much the time that you have taken to do this webinar. Totoo, marami po tayo natutunan mula sa disinfection, sa correct brushing of our teeth, and down to the skin cancers. So ulitin po at paki-on lang po ang ating mga camera. One more reminder for our OCMS members. Our colored dry fit shirt is now available through our officers. Patingnan na lang po ang sample na suot ni Dr. Manzo. Dry fit na colored shirt available in different sizes. Kindly contact any of the officers for those who are interested. And kindly stay po for the photo op